Hi, my name is Mark Lebwell. I'm the Dean for Clinical Therapeutics at the Icahn School of Medicine at Mount Sinai, and I am the immediate past chair of the Kimberly and Eric J. Waldman Department of Dermatology at Mount Sinai, where I had been the chairman for 25 years. My topic today is emerging treatment options for pustular psoriasis, and this is indeed an exciting time as we have a number of new treatment options emerging for pustular psoriasis. We're today going to discuss the pathophysiology of generalized and, to some extent, palmoplantar pustular psoriasis, including how they differ from that of plaque psoriasis and potential pathways for therapeutic targets. We'll evaluate patients with pustular psoriasis based on their manifestations, diagnostic criteria, and disease severity, and we'll identify clinical profiles and mechanisms of action of new and emerging biologic treatment options for pustular psoriasis. So let's start out with an overview of the pathophysiology of generalized pustular psoriasis and palmoplantar pustular psoriasis. Here are my disclosures, and of note in particular, I've been an investigator and consultant for Boehringer Ingelheim, one of the companies which does have a new treatment for pustular psoriasis. I have also been a consultant for Anaptys Bio, which has a drug in development for pustular psoriasis. And I've also been a consultant and investigator for almost all of the products in the psoriasis space, many of which have indeed been used for pustular psoriasis. Here is a photo of the disease we're going to be covering. This is generalized pustular psoriasis. It has a number of different presentations, but you can see that the primary lesion here is a pustule, as it happens to be a sterile pustule on an erythematous base. And this can be painful and devastating, as I will show you as we go through the next talks on generalized pustular psoriasis. The photo I'm showing you here is a picture of Mount Sinai in the early 20th century. And Mount Sinai was quite a famous institution back then. And one of the reasons for its fame was a description of Crohn's disease, which is called regional ileitis, in this original publication of that article in 1932. In fact, Ginsberg, who is a junior faculty member in the GI department at Mount Sinai, described Crohn's disease, and Burrell Crohn, being the chairman of gastroenterology at the time, put himself as first author. So we now know it as Crohn's disease, not as Ginsberg's disease, which it really should be called. And in fact, Crohn's disease is named after a famous dead doctor, and I never actually put my name first when someone else in my department has described or done something major, because I do not aspire to be a famous dead doctor. But nonetheless, we know it is Crohn's disease, and it actually has a fair amount of importance to generalized pustular psoriasis and to pustular psoriasis, because many of the treatments that we use for Crohn's disease are in fact triggered by trigger generalized pustular psoriasis. So, for example, infliximab, one of the first biologics approved for the treatment of Crohn's disease, is known to trigger both generalized pustular psoriasis and also, paradoxically, because infliximab treats psoriasis, it paradoxically can cause psoriasis as well. And all of the TNF blockers likewise can do the same. So here are publications of both generalized pustular psoriasis and palmoplantar pustular psoriasis induced by adalimumab. The other TNF blockers can induce pustular eruptions or palmoplantar pustulosis as well, and that's etanercept, which is not approved for the treatment of Crohn's disease. Certolizumab pegol, which is a pegylated TNF blocker, is approved for the treatment of Crohn's disease. And here you see a case of palmoplantar pustulosis induced by certolizumab pegol. But all of the TNF blockers have paradoxically been associated with the development of psoriasis, including pustular psoriasis. So here's a review of 120 cases of TNF inhibitor-induced psoriasis, not just pustular psoriasis, but psoriasis. And the timing of that can be anywhere from as early as 1 month after starting the TNF blocker to 105 months, many months or years after starting the TNF blocker. There's not an immediate temporal association. Probably the most characteristic lesion is involvement of the palms and soles, and even pustular involvement of the palms and soles. And palm and sole involvement can occur in psoriasis without a doubt, but it is not one of the most common sites for the development of psoriasis, so that it is interesting that in TNF inhibitor-induced psoriasis, it is very common. 43% of these 120 cases reported palm and sole involvement. Scalp involvement, on the other hand, is common in TNF inhibitor-induced psoriasis, but it's also very common in plaque psoriasis. So it does not help distinguish plaque psoriasis from TNF inhibitor-induced psoriasis. In this series, 41% of patients responded to topical therapy, but it is very common to have to discontinue TNF inhibitors in patients in whom psoriasis is induced. And here in this series, 43% inhibited TNF inhibitors, discontinued TNF inhibitors to get rid of their induced psoriasis. In those patients, if you re-challenge with another TNF blocker, psoriasis recurs in 52%. So re-challenging with another TNF blocker is not the ideal treatment. And here's a photo of classic TNF inhibitor-induced psoriasis. And as I said, it commonly involves the palms and soles. And here you see something that looks like palmoplantar pustulosis, pure pustules without a lot of psoriasis in the background arising in a patient with TNF inhibitor-induced psoriasis. But you can also get palmoplantar pustular psoriasis, which is shown here. And here you see with circles a lot of the pustules that occurred, and even the dried up pustules that occur in TNF inhibitor-induced psoriasis. And here you see involvement of the palms, again, involvement of the soles or heels, and involvement of the soles. You see a very big pustule there on the volar surface of the foot. Now, just like TNF inhibitors can paradoxically cause psoriasis, paradoxical induction of pustular psoriasis occurs with ustekinumab, another IL-12/23 blocker that is used to treat Crohn's disease. And in fact, that is often the treatment we go to when we have TNF inhibitor pustular psoriasis. But here you see ustekinumab itself can induce pustular psoriasis. Yet another drug that has been used to treat Crohn's disease is hydroxychloroquine, and that's well known as an antimalarial. And I will tell you a story about one of my patients who he had very little psoriasis, but he did business in Southeast Asia. And there are plenty of, especially now, new antimalarials, but even long ago, doxycycline, for example, is an antimalarial. There are plenty of antimalarials we can use in patients with psoriasis without running the risk of generalized pustular psoriasis. And in fact, my patient who did business in Southeast Asia took hydroxychloroquine for malaria prophylaxis. And in fact, he developed generalized pustular psoriasis. So the next time that he went to Southeast Asia, he didn't take the hydroxychloroquine, and in fact, he developed malaria. So, and as I said, he could have been put on doxycycline or other antimalarials, and today we have other antimalarials available that do not trigger generalized pustular psoriasis. And there are actually many reports of pustular psoriasis induced by hydroxychloroquine. You see two of them here. And actually multiple reports of hydroxychloroquine causing pustular psoriasis. Now, it turns out at around the late 1990s or the early 2000s, it was noted that hydroxychloroquine helps patients with Crohn's disease. And so there was a time where it became popular among gastroenterologists to use hydroxychloroquine to treat Crohn's disease. And I will tell you that during that couple of years where it was popular to use hydroxychloroquine, we had an epidemic of pustular psoriasis in our department because many of the patients in our enormous Crohn's clinic at Mount Sinai did develop pustular psoriasis. And there's another paper looking at hydroxychloroquine to prevent exacerbations of Crohn's disease or recurrences of Crohn's disease. Yet another drug that can trigger pustular psoriasis is lithium, well known, and here are several reports of lithium triggering pustular psoriasis. And finally, the most common cause of pustular psoriasis is also caused by a drug that is used to treat Crohn's disease, and that's systemic steroids. And the bottom article that you see here really points to the fact that systemic steroid dose reduction is what triggers generalized pustular psoriasis, and it is by far the most common cause of pustular psoriasis. And here you see, I found this fascinating. This was a 7-year-old girl who ingested half a tube of a potent topical steroid, clobetasol. So half a tube of 100-gram clobetasol tube, and that actually triggered pustular psoriasis in this 7-year-old girl. So these two articles questioned the association between systemic steroids and the triggering of psoriasis itself. And the top one did not present data, but said we simply don't have enough data to prove it. And I would say that that's accurate. We don't have data to prove that systemic steroids trigger psoriasis, but we do have a lot of anecdotal data, what might be called anecdata. And I'll show you one that came from a study, but also tell you a couple of anecdotes of my own. This was an article that came from an electronic database in a medical center where they didn't look at patients, but looked at their medical records. And they said they could not find evidence of psoriasis flaring following the use of systemic glucocorticoids. Now, I've already shown you a number of case reports indicating that occur, but there's a lot more data. And this is an article published 50 years ago in which they had an enormous number of patients. There were 73 patients treated in a study either with systemic corticosteroids or folic acid antagonists that predated the development of methotrexate. And it came from 73 out of 104 patients. What they reported is that nearly a quarter of the patients treated with corticosteroids died. And I'll actually take you through an example of one of my patients who didn't die, fortunately, but exactly what happened to their patients. The patient that you see here is a 28-year-old nurse who had a tiny bit of psoriasis on her elbows and had psoriatic arthritis. She went to a rheumatologist who treated her with 20 milligrams of prednisone. And she cleared up and her arthritis got better. And when he tapered the 20 milligrams down to 10 milligrams, she developed generalized sterile pustules all over her body. And you see her arms here. She also came, and then what happened, I'll go back one, he lowered the dose to 10 milligrams and her psoriasis occurred. So he put her back up to 20 and nothing happened. So he put her up to 40 milligrams. Everything cleared up. She thought he was great. Her pustules disappeared. Her psoriasis was fine. He lowered her from 40 milligrams down to 20 milligrams. And now again, her psoriasis occurred, pustular psoriasis. So he put her back up to 40, nothing happened. went up to 60, and again, everything disappeared. This time when he went from 60 down to 40, everything came out again. By the time I saw her, she had been on over 100 milligrams of prednisone for more than 6 months. And every time she tapered it, it would come out. And every time she went back up, it would go away. But now she's on 100 milligrams and can't get rid of it. We did manage to clear her. But the bottom line is systemic steroids, the reduction of systemic steroids regularly triggered the return of her pustular psoriasis. And when she came to me, she was covered in striae. She had a moon facies. She had central obesity. And we were able to clear her pustular psoriasis and gradually get her off the steroids. But it was by instituting all kinds of therapies, including PUVA and oral retinoids. And it was quite difficult to manage her, although we did eventually get her off it. But imagine at the age of 28, having these striae, which she didn't have before. Okay, so here is another trigger of pustular psoriasis, and that's pregnancy. And a condition which has been called impetigo herpetiformis has been implicated as a cause of pustular psoriasis, pregnancy being a cause of pustular psoriasis. And you see a pregnant patient here whose pustules are drying up. But there are many reports of pustular psoriasis of pregnancy, also known as impetigo herpetiformis, which is a misnomer because there's no infection here. These are sterile pustules. And this is a report of 2 cases with very different outcomes. And the outcomes can be that you terminate the pregnancy early, which of course results in miscarriage, or loss of the pregnancy, or you can terminate it late. And you can also use a number of medications. So for example, cyclosporine is widely used to treat generalized pustular psoriasis. Here's one that was successfully treated with infliximab during pregnancy. Now, here's a case of pustular psoriasis that occurred early in pregnancy, and here's a case that occurred late in pregnancy, and in fact was managed by induction of labor and delivery of the baby, upon which the trigger was removed and the pustular psoriasis can improve. Infections have also been implicated as causes of pustular psoriasis, and here's a report of Zika virus and another of Epstein-Barr virus triggering pustular psoriasis. And here is a report of streptococcal bacterial infection triggering pustular psoriasis. Now, the mechanism of action of pustular psoriasis has indeed been identified in some patients. And here was a classic groundbreaking article in which a deficiency in interleukin-36 receptor antagonist was identified as the cause of pustular psoriasis in a number of families. And what they showed here is that because of the deficiency in the antagonist of IL-36, patients develop pustular psoriasis. And here they report that unopposed IL-36 results in generalized pustular psoriasis. Now, interestingly, here's another inflammatory bowel disease tie. Here they looked at active inflammatory bowel disease and reported that gene expression of anti-IL-36 receptor antagonist was increased in colonic tissue from patients with active versus inactive ulcerative colitis, and in comparison to the non-inflamed control group, and that was statistically significant. They also reported mRNA expression of IL-36 family members was increased in colonic mucosa in active UC and versus Crohn's and non-inflammatory control groups. So there is a role here in inflammatory bowel disease as well. Now, this is a schema that was drawn in the article that's quoted below to look at the pathophysiology of GPP compared to plaque psoriasis. So in GPP, IL-36 is a key player. It plays a central role. And it is neutrophil-derived proteases stimulate IL-36 formation by keratinocytes. dendritic cells or Langerhans cells. And here you see a dendritic cell releasing its cytokines and recruiting neutrophils, T cells, and other dendritic cells and monocytes. They secrete IL-6, IL-23, and IL-1, which results in T cells releasing or recruiting monocytes and neutrophils. And they, in turn, release proteases, creating a vicious cycle here. Look at plaque psoriasis in contrast. And in plaque psoriasis, the key players here are IL-17. And the other cytokines listed here, TNF alpha and IL-22 and IL-23, all play roles, but the key roles are played by IL-36 in generalized pustular psoriasis. And what you're looking at here is the IL-36 pathway and how it impacts pustular psoriasis. So you're looking at in red the IL-36 molecule, and there are 3 IL-36 isoforms, but it interacts with the IL-36 receptor and is specific to the IL-36 receptor. The IL-36 receptor antagonist, which is shown in green here, blocks IL-36 from binding to the IL-36 receptor. Under normal conditions, IL-36 receptor and antagonists take turns in regulating the IL-36 pathway. But when there is either a deficiency of IL-36 receptor antagonist or an overexpression of IL-36 is when you get the inflammatory response that leads to generalized pustular psoriasis. And that is shown here. So again, it's either overexpression of the agonists, IL-36, that result in excessive signaling, or loss of function mutations in the antagonists that allow the IL-36 pathway to run amok, creating generalized pustular psoriasis. Now, imsidolimab is one of 2 biologics in development for the treatment of generalized pustular psoriasis. And you see here a functional receptor antagonist that blocks IL-36 from attaching to its IL-36 receptor. Here's a dysfunctional receptor, which indeed allows the IL-36 interaction to occur and run amok. And in patients treated with imsidolimab or the other antibody that binds to the IL-36 receptor, those antibodies also prevent the interaction that allows the IL-36 and IL-36 receptor to join together and trigger inflammation that leads to GPP. Now, so here's the pathogenesis. Keratinocytes release IL-36 and IL-36 receptor antagonist. The increase in IL-36 leads to GPP. The increase in IL-36 receptor antagonist reduces the likelihood of GPP. Loss of function mutations in the IL-36 receptor antagonist, which is called DITRA, deficiency of the IL-36 receptor antagonist, results in increased inflammatory cytokines and GPP. And IL-36 RN mutation frequency in GPP so that's the DITRA. That frequency is 23.7% in generalized pustular psoriasis. So less than a quarter of patients with GPP have that mutation, and it's 5.1% in palmoplantar pustular psoriasis. And let it not be said that we didn't mention genes. There are many genes that have implicated in the pathogenesis of generalized pustular psoriasis, but here are the genes implicated in the development of palmoplantar pustulosis. And You see the gene list on the top, HLA-CW6, card 14, genes in the IL-19 family, IL-20 and IL-36. And then there are medications like TNF blockers can trigger palmoplantar pustulosis. Same for stress, smoking, irritants, friction, and trauma. And triggers that stimulate IL-1 and IL-36 axes also increase Th1 and Th17 cytokines, as we see in psoriasis, but we also see in palmoplantar pustular psoriasis. So with that, I hope I haven't put you to sleep, and we'll, in our next talk, discuss clinical implications of IL-36. It's a pleasure to be here again, and I am glad now to be speaking to you about strategies in the diagnosis and treatment with emerging IL-36 antagonists in pustular psoriasis. So this is a photograph of the hallmark lesion of pustular psoriasis. These are sterile pustules on an erythematous base, and you can imagine the havoc they wreak with patients when they cover most of the cutaneous surface, which is typically what occurs in generalized pustular psoriasis. So you see many of these here, and you can imagine how uncomfortable this is, how irritated even just the breast rubbing against the chest can be for this poor patient. Again, here are more photos, and this is a miserable condition. Even when it starts to dry up and heal, it is pretty miserable, as you see here and here. And the skin is just horribly inflamed, as you see in these patients. Now, we looking at the skin and worrying about what it looks like is one thing, or even that it hurts or itches is another. But think about what it does when you lose all of the protective functions of the skin. And in fact, generalized pustular psoriasis can be a life-threatening condition. We don't really think about all the things our skin does until we lose the protective functions of the skin by a condition as severe as generalized pustular psoriasis. Our skin plays a major role in maintaining the temperature of the patient. So patients with generalized pustular psoriasis can come in hypothermic because they lose so much heat through that compromised skin, or they upset their body's thermostat and they can come in febrile. And often patients will come in with fever of 101, 102 or higher. And then you have to worry, are they septic? And we'll talk about that a little bit more. They lose fluids through the skin. So patients can develop hypotension because of their body fluids are reduced so much that they underperfuse their vasculature and become hypotensive, and then can go into renal failure because of the hypotension. So they actually go into shock because of loss of fluids. And when we admit patients with generalized pustular psoriasis, we have to strictly account for their intake and output to make sure they are not becoming hypovolemic. Patients can come in with hypoalbuminemia when you check their chemistry profile because they lose protein through the skin. They can come in with a microcytic anemia because they lose iron through the skin. And sometimes when they come in, we'll see an elevated white blood count and even a hematocrit that is not low because they are hemoconcentrated because they've lost so much fluid through their skin. But iron deficiency anemia is not only common, it is almost uniform in patients with generalized pustular psoriasis that is ongoing. Patients lose electrolytes through the skin, resulting in electrolyte imbalances, and things like hypocalcemia are common in generalized pustular psoriasis. They go into high output cardiac failure because the demands of this generalized inflamed skin is so overwhelming that the heart can't keep up with that demand. And patients routinely will develop pedal edema bilaterally. In fact, it's very common to see patients admitted to the ICU. They have swollen legs. They're shivering because they've lost the temperature, the thermostat protections of intact skin. and their families are often around that worried that they're going to die. They look incredibly sick. And of course, the worst side effect, and the one that most commonly leads to death in generalized pustular psoriasis, is sepsis. We never think of our skin functioning as a barrier to infection, but in fact, Staph aureus, there are many reports of patients having Staph aureus enter the bloodstream, cause sepsis, and end up in the demise of the patient. Now, palmoplantar pustulosis is shown here, and there are two versions of this. One of them is sterile pustules on the palms and soles, and the other version is palmoplantar pustular psoriasis, where the patient has psoriasis with palmoplantar pustular psoriasis associated with it and associated with skin psoriasis. But you can imagine with either of these how miserable this is. Imagine this being on your foot, and every step you take hurts. Imagine it being on your hands and trying to shake hands with people. They act in revulsion. Imagine every time you button your shirt, you get pus and blood stains on your shirt. And imagine how painful it is. And again, when it's on the feet, every step hurts. Even when it dries up, and here you see pustules that have dried up, so they're left on the soles of this poor patient. This patient, I remember her saying to me, all she wanted was to be able to walk down the aisle at her wedding, but every step she took hurt. Imagine when it's more chronic and the patients have skin that is, this is palmoplantar pustular psoriasis. Every time they take a step, it cracks and bleeds. And imagine this form of pustular psoriasis, which is called acrodermatitis continua of Halepo, where patients get pustules around the nail bed and in the nail bed, causing crumbling of the nails. Okay, well, let's talk about epidemiology of pustular psoriasis. You see here that the prevalence of generalized pustular psoriasis ranges from 0.0001% to 0.0009%. I mean, that's one in, if I'm doing the math here, 1 in 100, 1 in a million, actually, or to 9 in a million. If you, that number is actually increased in Asian compared to Caucasian populations. 7.46 per million in Japan versus 1.76 per million in France. Many patients have psoriasis, but some patients have pure pustular psoriasis without plaque psoriasis. Now here's palmoplantar pustulosis, which is much more common. Here it is 1 in 10,000 to 5 in 10,000, but approximately 10 to 25% of patients with palmoplantar pustular psoriasis also have chronic plaque psoriasis. So so we have two distinct entities here, palmoplantar pustular psoriasis and palmoplantar pustulosis. Now, with generalized pustular psoriasis, there's actually a real mortality rate between 4 and 7%. The rate of severe complications is 17%. The mean number of hospitalized days when a patient flares is 10.3 days. So this is an awful disease with many severe complications. Here we see an article which characterizes flares in generalized pustular psoriasis based on a study in France. And what you see here, apart from the demographics that are shown, are, and I should point out, this is data from 2012 to 2015, and it only includes inpatients. It's an enormous series, though, 569 inpatients. The admission to ICU was required in 25%. The number of flares per patient was a mean of 1.4. The number of deaths was all-cause deaths as high as 24.4% over that 2012 to 2015 time period. And within flares within 4 weeks of the last, deaths within 4 weeks of the last flare was 2.6%. So it can be a fatal condition. Okay, what about diagnosis? So the main item in the differential diagnosis of GPP is acute generalized erythematous pustulosis, AGEP. And we'll talk about how you distinguish GPP from AGEP. Subcorneal pustulosis we'll discuss as well. Some consider it as just a form fruste of generalized pustular psoriasis. Folliculitis that is generalized can be mistaken for GPP. Pustular drug eruptions, we've shown you some of those, can be mistaken for generalized GPP. A condition called miliaria, which is pretty much I've always thought of as blocked sweat ducts, but miliaria can be mistaken for GPP, as can candidal infection. And with palmoplantar pustulosis, the differential is contact dermatitis, dyshydrotic eczema, which can be vesicular, which then becomes pustular, atopic dermatitis with secondary infection, and candidal infections in palmoplantar pustulosis. So here you see AGEP that is resolving. And you see here, it's very superficial. The skin underneath AGEP is normal. And the patients, when you go in to see them, are not that ill. And that's really how we differentiate AGEP. But there are other factors too. But you see normal skin underneath that skin involved with pustules. So GPP can be chronic or recurrent. It is most commonly triggered by steroid withdrawal or a known drug cause such as antimalarials, beta blockers, ACE inhibitors, or lithium. The histology shows subcorneal pustules with neutrophils, and pustules of Cohoy are well known, and there can be psoriasiform changes in patients with generalized pustular psoriasis. Now, AGEP, in contrast, is acute. It's triggered by a drug, often an antibiotic, NSAIDs or anticonvulsants. And the histology is intraepidermal or subcorneal pustules with neutrophils, but there can be, for example, necrotic keratinocytes, and eosinophils, and there's often a lack of epidermal thickening. Now, in this paper, they make the argument that subcorneal pustular dermatosis and pustular psoriasis are very similar and practically the same thing. This is a pustular drug eruption induced by ferrous fumarate, so there can be pustular drug eruptions, but the diagnosis is a clinical diagnosis. It involves crops of sterile pustules on inflamed skin. A history of psoriasis vulgaris is helpful, but it's not 100% of cases. A detailed drug history to rule out triggers and distinguish from AGEP. The laboratory evaluations you would do in GPP involve primarily the CBC and chemistry screen. Cultures of pustules can be taken, but should be sterile. CBC and DIF, gram stains, KOH prep, can help rule out other causes of pustulosis. Ultimately, a skin biopsy can be helpful, and genetic screening for DITRA can be helpful as well. Now, there are many diagnostic criteria that have been developed for GPP. An old one is by Umezawa, and he looked at systemic symptoms as a requirement, including fever and malaise. He also reported multiple septic pustules and erythematous skin, which all of the criteria basically should have. On histology, Cohoy spongiform pustules. And in terms of lab abnormalities, a shift to the left of leukocytes can occur. So as can elevated sedrates, CRP, anti-streptolysin O, elevated immunoglobulins, hyperproteinuria, hypocalcemia, all of which we've talked about, and recurrence of these clinical and histologic findings. Now, the Erasmin data, which is a European database, look at, again, sterile pustules on non-acral skin, with or without systemic inflammation, with or without plaque psoriasis, and either relapsing, meaning more than one episode, or persistent, more than 3 episodes. And yeah, the last criteria are by Fujita in Japan. And they also require systemic symptoms that we saw earlier with the Yumezawa criteria. Systemic or extensive flush accompanied by multiple sterile pustules, neutrophilic subcorneal pustules, and recurrence of all clinical and histologic findings. Now, palmoplantar pustulosis versus palmoplantar pustular psoriasis is another important differential in pustular disease. So typically, palmoplantar pustulosis is limited to the palms or soles, but can spread to the lateral sides of the hands and feet. In palmoplantar pustular psoriasis, most cases occur with psoriasis at other body sites. Onycholysis, pitting, subungual pustules, and dystrophy occur in palmoplantar pustulosis, but also can occur in palmoplantar pustular psoriasis. Upper respiratory infections, psoriatic arthritis, and smoking are triggers of palmoplantar pustulosis. Psoriatic arthritis is associated with palmoplantar pustular psoriasis. The family history for psoriasis is non-existent in palmoplantar pustulosis, but does agree in palmoplantar pustular psoriasis. In terms of other symptoms, palmoplantar pustulosis is more often painful. Palmoplantar pustular psoriasis is more often itchy. The family history of psoriasis generally does not occur in palmoplantar pustulosis, but can occur in palmoplantar pustular psoriasis. The histology for palmoplantar pustulosis involves sterile intraepidermal pustules filled with the eosinophils and neutrophils. The histology of palmoplantar pustular psoriasis is orthokeratosis, alternating with foci of parakeratosis and the existence of inflammatory cells. Okay, and then in terms of genetic susceptibility, it can occur in both conditions, but is certainly more common with the IL-36 and IL-36 RN genes. Okay, what about treatment? So there have been a lot of problems to getting approval of medications for GPP. First of all, the condition is rare. Second of all, there are no US guidelines. Thirdly, there are no great evaluation tools. So think about the PASI score, for example. The three main components of the PASI score are erythema, induration, thickness, and scaling. So you can have palmoplantar psoriasis with no erythema or very little, and no or very little scaling. But what's critically missing is induration. There is no induration in palmoplantar pustulosis or in generalized pustular psoriasis. They're just pustules on red skin. Okay, and the endpoints for studies are also flawed. There are no drugs approved for generalized pustular psoriasis in the US. There are some drugs approved in Japan, but when you look at those approval, they're based on any improvement at all. So even a little bit of improvement qualifies as a treatment success in some of those studies. And that is why there are no approved treatments in the US. In terms of treatment, we do want to decrease crusting, scaling, and discomfort. So a lot of topical corticosteroids are used, total body wet wraps are used, and whirlpool treatments are used. But there's a real problem, and that showed up in this Coravitas questionnaire, where dermatologists were asked whether they thought the treatments for psoriasis, what the typical time was. And the vast majority, 72%, considered the treatment options too slow to control flares. And you see that shown in a diagrammatic form here. Now, so here I've described a disease which is awful. It severely affects patients. It's life-threatening, and you want to reverse it quickly. But of the treatments listed here, which works the fastest? And the answer is systemic steroids do. But I'm going to again show you the publication by Ryan and Baker. Nearly a quarter of patients treated with corticosteroids died. And here's some more data on it. And this is published 2 years later. Now they're up to 155 patients with 106 followed. And nearly a little under a third of them have died. So 1/4 of the deaths, 1/4 of the patients had GPP that was steroid induced. 10 patients did not improve until the steroids were withdrawn, and a comparison of steroid and untreated cases strongly suggests that steroids prolong their illness. 7 deaths were clearly attributable to steroids, and this treatment was probably a factor in their deaths. And those figures included the 8 patients who died from uncontrolled GPP, 7 of whom were on steroids. Severe side effects due to steroids were common. So steroids are clearly a mistake. Now let's go to our biologics. This is a photo of a patient who came in on a Friday with severe generalized psoriasis that you see here. But even more to the point, his hands were so swollen that he couldn't use them, and his feet were so swollen that he could hardly walk. Now, what triggered his psoriasis? Well, he had a little bit of psoriatic arthritis, went to a rheumatologist who gave him prednisone, and as he tapered the prednisone, he broke out in generalized pustular psoriasis. Generalized severe psoriasis, almost erythrodermic. And here you see him a week later. Now, this is not pustular psoriasis, but you see for plaque psoriasis a week later, the patient is dramatically better. And here you see his hand, marked swelling of his hand. And a week later, you see that the swelling is dramatically reduced. This is a publication in which we showed that the IL-17 blockers are among the fastest drugs we have to treat psoriasis. And when you have a life-threatening condition you really want something that works quickly. So, and you see here, brodalumab, ixekizumab, and secukinumab work the fastest. Here's PASI 75. Again, you see those 3 drugs work the fastest. And PASI 90, those 3 drugs work very fast, but indeed, infliximab, infliximab also works fairly quickly when it comes to PASI 90. This is a study that we did for Taltz. And what you see here is the impact of ixekizumab at week 1. Let me do that again. This is a study that we did for ixekizumab. And what you see is as early as week 1, we see psoriasis beginning to clear, marked improvement by week 2, dramatic by week 4. By week 8, there's hardly anything left. And by week 12, the patient is almost clear. And here's what happened with ixekizumab. There is some improvement, decent reduction in psoriasis, and the proportion of patients to achieve PASI 75, 90, and 100 is good. The dilemma is we don't really have good endpoints in those patients, and hopefully we will develop those. Ixekizumab, same story. Again, what they're looking at here are treatment satisfaction scores, which are not based on a GPP-specific score. And by the way, the EP is erythrodermic psoriasis, GPP is generalized pustular psoriasis. But you do see some benefit. And in fact, I believe that in Japan, IL-17 blockers are indeed used for approved for pustular psoriasis. This is brodalumab. Now here again, this is a very gradual improvement in psoriasis. And because of that, it would not be one of my go-to drugs. Although it is actually the fastest of the IL-17 blockers. if we had a better choice, we would go to it, but certainly brodalumab is the fastest of the IL-17 blockers, but for pustular psoriasis, it's not nearly as fast as it is for plaque psoriasis. Now, the National Psoriasis Foundation published a guideline in 2012. So again, this is before we had many of the drugs we currently have. And they mention acitretin, cyclosporine, methotrexate, and TNF blockers as first-line therapies, and the other adalimumab, etanercept, and sertraline plus UV are second-line modalities in this setting. So here you see several articles on cyclosporine working dramatically for pustular psoriasis. Methotrexate's also been reported, although it would not be my treatment of choice because it is a relatively slow drug. Here you see apremilast being used to treat pustular psoriasis. Again, it's a very slow drug. I would not be my treatment of choice. Here's infliximab being used to treat pustular psoriasis, and it is a step ahead of the others because it is fairly rapid in its efficacy. And here's etanercept, again, slow drug, not my treatment of choice, and adalimumab, which was fairly fast in the treatment of pustular psoriasis. Now, here again is a pustular psoriasis paper and a patient treated with ustekinumab. And here's a case of guselkumab, an open label study in which patients with generalized pustular psoriasis were treated with guselkumab. And this is the phase 3 Japanese study. And what you see is reasonably quickly, but not immediately, guselkumab does in fact result in an improved, much improved, or minimally improved endpoint. So think about that. If they improve even a little bit, they've achieved treatment success. Now, there are many reports of the IL-17 blockers used to treat pustular psoriasis. And I think actually if you came to Mount Sinai on a weekend and saw one of my residents, they've been trained to use drugs that are fast for pustular psoriasis. So they usually will turn to an IL-17 blocker and often to IL-17 blocker, and often they'll treat them actually with oral retinoids as well. Speaking of oral retinoids, here's a paper on isotretinoin, which seemed to work as well as etretinate. And etretinate was the precursor for acitretin, which is the retinoid currently in use for psoriasis and for pustular psoriasis. But here's a patient before and after isotretinoin. So it can be dramatically effective, unfortunately not that predictable. Now, spesolimab is an anti-IL-36 receptor antibody. And what you see here, after an infusion on day 0, you see that the global assessment score of 0 or 1 clear or almost clear goes up to nearly 80% of patients in one day. So here's the initial trial design for spesolimab, and patients are given an intravenous dose of spesolimab 900 milligrams compared to placebo, and they were randomized 2-to-1 to receive the active arm. And then during the ensuing week, if they didn't get better, they were given the option of being treated again with an open label IV infusion. So that is the episodial trial design. After day 8, all patients were allowed to receive all patients after week 1 are allowed to receive open label spesolimab because it worked so well. So again, here's the primary endpoint: the proportion of patients with a generalized pustular psoriasis global assessment score, pustulation score of 0. That was the primary endpoint. And then a generalized pustular psoriasis global assessment total score, not just pustulation, of clear or almost clear. So in terms of the demographics and baseline characteristics of the patients here, they were mostly moderate and some severe, no mild patients. And in fact, at week 1, looking at that pustulation score of 0, at week 1, it was 54% in the spesolimab group, only 6% in the placebo group. Then looking at clear or almost clear in the global assessment score, the difference was 43% to 11% in the patients who got spesolimab compared to the ones that got placebo. And you see the mean improvement in GP PASI score, which again, I would question the validity of a PASI score, but the mean improvement was 82%. Okay, here are the adverse events, and you see here that I'll look at headache was increased in the placebo group compared to the spesolimab group. Same for pyrexia, same for hyperuricemia. In terms of fatigue, there was more fatigue in the spesolimab group. And in terms of the other side effects that are shown here, I'm highlighting vomiting now, and that was more common in the placebo group than in the spesolimab group. So fatigue does stand out there. And we'll talk about other side effects coming up now. Myalgia is also more common in the placebo group, probably because of the severity of the generalized pustular psoriasis. Now, when you look at other side effects, again, the baseline GP PASI, and divide them into people who have a median score at baseline of less than 27 versus those over 27. All of the side effect happens in the ones who have more severe disease, and they primarily occur in single patients who are treated with placebo, because the condition at baseline can be severe. Now, if you look at other adverse effects, sorry, let me start this over. Now, if you look at other adverse effects, there were 2 severe adverse effects in, there was 1 severe adverse effect in the spesolimab group, 1 in the placebo group. And if you compare them with the patients who are less than a median of 27.2 baseline PASI score, the low disease scores, it's only in the high disease scores where the spesolimab exceeds placebo in terms of severe adverse effects. And the same is true with investigator-related adverse effects. But where we see spesolimab emerge is in the people with severe disease who had serious AEs. And you see here in the ones with more than a median baseline of 27.2, 11.1% had serious AEs that required prolonged hospitalization. If you look at infections also, it occurred in that group. Urinary tract infection, bacteremia, bacteriuria, herpes, oral herpes, or pustules. And those are in the spesolimab group. Also, when you look at upper respiratory tract infections, that occurred in the spesolimab group in the patients with less severe disease. Okay, let's talk about imsidolimab now. This is the design of the imsidolimab trial, and subjects with moderate to severe GPP were treated with an IV dose at baseline of 750 milligrams. And They were then treated, this is the phase 2 study, they're then treated with every 4-week injection of 100 milligrams subcutaneously. And then the primary endpoint was looked at week 16. And I will point out in both spesolimab and imsidolimab, because the condition can be so severe, rescue medication was allowed in non-responders. So in terms of clinical global impression, you see that the response rates here, and you see that the patients had at week 4, 50% were very much improved, 25% improved. At week 16, 50%, 12.5%, and 12.5% minimally improved. So let's go to the clear or almost clear patients at week 4 and week 16 respectively. And you see that 50 and 75% of subjects had generalized pustular psoriasis global assessment score of clear or almost clear. And when you look at disease signs and symptoms, there's a rapid and sustained improvement of disease signs and symptoms with imsidolimab, rapid and sustained reduction of the area of erythema and pustules. And if you look at the scores at day 8 relative to baseline, there's a 60% reduction in erythema with skin and pustules as early as day 8. By day 29, that goes down to 94%. And here is a clinical photograph. Here you see the patient at baseline after the 4 weeks of first IV and then sub-Q injections. Very much improvement at week 4 and at week 16. So 37.5% of subjects in this study reported 5 treatment-related adverse events, nausea, nosocomial infection, oropharyngeal pain, and moderate psoriasis and vomiting were all reported. 25% of patients had serious adverse events, one with sepsis due to a nosocomial infection on day 7, and one who had COVID. No subjects discontinued the study due to an adverse event. So the bottom line is that these drugs are highly and rapidly effective and will likely impact the way we treat generalized pustular psoriasis. They do have some side effects, and infection is of concern, but at least we finally have a condition that reverses this life-threatening generalized pustular psoriasis. So with that, I think I am out of time and will close the lecture. Thank you very much.